quite a good opportunity for maybe the non-clinical stuff to get more of a kind of feel for what mesothelioma looks like, just in terms of visualisation. It's helpful. And we're really fortunate to have both Simon and Gordon, who are two of our radiologists from the National MDT, here to talk us through it. So I'm going to just hand over directly to Simon.
So good afternoon. As Kevin said, I'm Simon Sheridan, one of the radiologists from Glasgow, and Gordon and I have been asked to speak to you this afternoon about the imaging of mesothelioma. Now, I've been involved in the National Meso MDT since its inception in 2019, and before that, in the staging of mesothelioma in the west of Scotland, or West Glasgow rather, lung cancer MDT. And we're all aware of the shipbuilding and industrial heritage of the west of Scotland that led to many of the asbestos exposures and subsequent cases of mesothelioma. But interestingly, earlier in my career, I did a fellowship in Perth in Western Australia, and as Kevin alluded to, this is another one of the kind of world hotspots of mesothelioma. But for a different reason. This was a place where they mined asbestos very extensively, especially the blue asbestos, such that there's whole towns in the north of Western Australia which are now uninhabitable because of asbestos contamination, and this is one of them called Wittenham. So I've been looking at mesothelioma and scans for quite a long time now, and so hopefully I can share some of that experience with you guys today. So this is what we're going to have a look at today. We're going to basically go through most of the time looking at CTs, but we'll talk about plain films to start with. We're going to look at the TNM and how we use that to stage, and show you some of the characteristic findings. Now, you may not have met a radiologist in live before. We're very simple creatures. We like nothing better than hanging out in dark rooms and looking at pictures. So because this is a radiology talk, it's going to be sit back and relax, because this is going to be 20 minutes of looking at pictures, and I'm now going to give you a no difficult graph and a no difficult table guarantee, okay? So we're going to start with the plain film, and although the plain film is clearly it's a limited utility in the staging of cancer and meso in particular, it is still the first imaging that a patient with respiratory symptoms has. And so it's worth spending, and it does have a role in mesothelioma and its management. So we'll just spend the first few minutes maybe talking about that. So just to get your eye in, this is what is a normal chest X-ray. We've got the heart in the middle, we've got the mediastinal structures with the aortic arch, the black bits are the lungs, the bright white bits are ribs. Now, if you keep that picture in mind, you'll see that's a normal one. So what might we expect to see, or what might give us the suspicion that there's mesothelioma about? Well, this is quite a common thing we'll see first up, and this is a large left pleural effusion. So pleural fluid collects in the pleural space as a result of the tumour, and we get this classic meniscus sign, and that's quite often what we'll see early in the process. And the chest X-ray is also useful because we can use it to monitor treatment of these effusions. And here's the same patient after the insertion of this chest drain, and you can see that opacity down there has largely gone because that effusion has been successfully drained. What else might we see? Well, next two slides are going to show you the kind of classic appearances of mesothelioma on a chest X-ray. Now, these are clearly, they're advanced cases, but what we can see here is the mesothelioma tends to encase the lung, and see this side's smaller than this right side, which is normal. And here we've got a kind of rind of opacity, this white stuff, circumferentially around the lung, and that's tumour encasing that left lung and causing it to contract. Here's another example, but on the right side this time, so normal left lung, a rind of abnormal opacity round, circumferentially around the lung, contracting that lung. So this is the kind of classic appearance of meso on a chest X-ray. But as I say, late disease, and we want to be diagnosing it earlier than that with CT and so on. Here's another example of this time a massive pleural effusion. This time, everybody can spot this side's abnormal, it's totally white. There's space occupation. This is occupying space and creating tension, pushing the heart to the left. And this is a tension pleural effusion, which is successfully treated by the insertion of this chest drain, which you can see here. So we know that what might alert us to the fact that a patient has been exposed to asbestos, and of course we've all heard of pleural plaques, which we look for in chest x-rays, we look for in CTs as a marker of asbestos exposure, and it's used as it was one of the inclusion criteria, wasn't it, in the studies that we'd heard about earlier. And this is what they look like in chest x-rays. So see this bright white line here, and here, and here. These are calcified pleural plaques, and they tend to run along the line of the rib very characteristically. Or in this next example, we can see them outlining the hemidiaphragm, bright white lines. And this is the calcium of the asbestos-related pleural plaque that we see that lets us know that this person has been exposed to asbestos, and we should be thinking about other asbestos-related diseases, in particular mesothelioma. Here's another example. You have more extensive plaques up in the upper zones here. Sometimes this is maybe the best example. They describe as having a holly leaf type appearance. So that was a quick run through of the chest x-ray and how we might use that. It's the initial assessment often of respiratory illness. They're widely available. Every department, every unit, even GP practices have units where they can take x-rays. We might see evidence of asbestos exposure with plaques. We might see pleural effusions which need investigation. And in later cases, we might see the circumferential pleural thickening. We can also use it to assess interventions like drainages. And sometimes if progression is gross or regression is gross, we might be able to detect that in plain film. But it is limited. It's insensitive for early disease. We can't stage with it. It lacks the accuracy for staging, and we can't see nodes very well with them either. So the main part of the talk is going to be about CT, which is really the workhorse for the staging and diagnosis of mesothelioma as far as imaging goes. Now, not all CT scans are created the same, and we do need certain things to be able to assess the pleura properly. We need thin section CTs because that allows us to recreate multiplanar reformats, which we use importantly to assess the tissues. We need to have intravenous contrast on board because that brings out the pleural enhancement, and that lets us define the pleura more clearly. The phase of enhancement is important. It needs to be a venous phase, which is 60 to 90 seconds. Now, CT pulmonary angiograms, which are used to diagnose pulmonary embolus, are almost ubiquitous in hospitals now. They're so commonly used, and so much so that we will sometimes pick up malignancies on them. But importantly, the CTPA is not adequately timed for pleural effusions, and that's why we need to have a slightly later phase scan at 60 or 90 seconds. And one of the QPIs for the meso meeting is that they've had a proper venous phase CT. So I think to understand how meso affects the chest, we're going to have to have a grasp on some basic anatomy of the chest wall and the thorax. So just very quickly, we go working from the inside out. We've got lung, and then the first thing we meet is the visceral pleura, separated by a kind of potential space from the parietal pleura. And then deep to that is what's called the endothoracic fascia, which is a kind of loose collection of connective tissue and fat, and then the innermost intercostal muscle, and that's what creates the intercostal stripe on CT, which I'll show you in a minute. So it's important to realise that this is a healthy patient, normal pleura, that we can't really appreciate pleura on CT. So for example, here where this arrow is, this is the aortic arch and the SVC, the trachea, the black bits of the lungs. The black bit in the middle here is fat within the mediastinum. And between the black of the lung and the black of the mediastinum, we can't really appreciate there's no definable structure. Similarly, deep to the ribs, we don't see any tissue in the normal, healthy state. And just to close in on the pleura, so this curved arrow shows you this intercostal stripe, which is made up of the pleura, the most intercostal muscle, and the endothoracic fascia. And then deep to that, we've got subpleural fat before we encounter the intercostal muscles. So this is what I'm talking about when I mentioned earlier multiplanar reformat. This is a coronal slice through the chest with the heart, the liver down below the diaphragm, lungs and ribs. And here you can appreciate there's no real definable structure between chest wall and lung. You can't really see the pleura at all on CT in a healthy state. This is the sagittal plane where it's sliced through in a kind of longitudinal plane like that. So this is moving on to the sort of disease state, I guess. This is the HTNM classification, which is the one we use currently. I'm not going to talk through it. I'm just going to show you some pictures. But first of all, I'm going to show you a situation that we come across not infrequently in the meso-MDT. So what we've got here is a CT scan that shows a large pleural effusion. Now, we might know from the clinical history that this patient's been exposed to asbestos. So we're concerned that this pleural effusion is due to malignancy, either maybe lung cancer or maybe mesothelioma. But the pleural looks normal. You know, there's no lumps or bumps in the pleural, there's no thickening, deep to the ribs, you don't see anything. But we're still worried about this. And I think this is a scenario that we come across semi-regularly at MDT. And if Selena or Rocco puts a scope in there, they might see millions and millions of tiny tumour drops on the pleura that we just can't appreciate in CT. So this is early stage disease. We call it TX because we can't diagnose it in CT, but in all likelihood it's going to be early stage disease like T1 probably. So that's TX. So now, and this is the same patient, and here's a potential pitfall. So pleural effusion. Oh, but look, here we've got some thickening here. Is that cancer? Well, no, it's not actually, because what we've got here, if we look carefully, that's the same, that stuff there is the same density as this stuff down here. So what we have here is this pleural fluid that's tracked over the surface of the mediastinum, and that's not to be mistaken for tumour bulk. So enough about tumour that we can't see. Here's some tumour that we can see, and I'm just going to work my way through the T staging. So here again, we've got a CT scan. Now, these bright white lines here, deep to that rib and deep to the rib here, these are the pleural plaques that we saw in the chest x-ray. So we know this is a patient who's been exposed to asbestos. We've got a large pleural effusion, so we're suspicious that there's malignancy about. And then if we inspect this area here, that I drew your eye to before, on this side, again, no discernible structure between lung and mediastinum, but here now we've got this thin rim of soft tissue thickening there, and that's indicative of tumour, and that's this tumour that's confined to the pleura alone, and this is what we have T1 disease. Again, same patient, in the coronal plane this time, and I think with the benefit of these arrows, you can see there's a slender rim of tissue there now, outlining that thorax, and that's the early T1 disease that we see in CT. This is another example of T1 disease, this time again, pleural effusion. And here's a more solid, a larger lump of tissue, a larger lump of tumour. It's still T1 disease. And we can see there, because if we do the close-up, we can still see the subpleural fat is preserved. And so this is confined probably to pleura alone. So moving up through this is T2 disease. Now, T2 disease, by definition, has invaded through the pleura and into either diaphragm or lung parenchyma. Now, I think this is one of the more difficult. Early stage disease is difficult at CT. We're not very good at it. And T2 disease, I think, is particularly difficult because it's lung parenchyma and diaphragm. And I'll show you a picture here. So just to get your eye in, this is, again, a coronal plane. We've got a large pleural effusion. This is the liver down below here. On this bright white stripe here, that's a normal diaphragm. So it's well defined, it's slender, it's thin. And on the right side here, it's different. If we zoom in, we can see it's thickened and nodular. So the diaphragmatic muscle is almost certainly involved here. I'm fairly confident it's not any higher stage because we can still see a black line underneath that, and that's a fat beneath the diaphragm, and before you reach the liver. So this is T2 disease, or at least I hope it is, because that's what I told the MDT. So moving on, T3 disease, again, more progressive disease. The T staging is about levels of invasion, and this is a bit further invasion into the chest wall. And a T3 disease, the first one here is an example of invasion into the endothoracic fascia. Now, you can see here, we've got a lump of tumour. It looks quite like the other one did, which was, I told you was T1, but this time you can see it's stranding of that subpleural fat there. And again here, we've got a lump of tumour that's extending itself into that subpleural fat stripe and probably on towards getting close to rib. And that's going to be invasion. And we know that's, because it's gone beyond the intercostal stripe, we know that it must be into and through the endothoracic fascia, which is a descriptor, in fact, for T3 disease. So the other descriptors for T3 disease are this one, for example, where we've got now quite nodular, thick tumour up here, and that's invading into this anterior mediastinal pericardiac fat, consistent with T3 disease. Here's another example of T3 disease. This is at the pericardium. So this is the heart in cross-section with the left atrium, left ventricle and the right-sided chambers. And you can see on the right side, the pericardium, which is the tissues that line the outside of the heart, are thin and slender on this side where it's normal. But you can see it's different on the left side. There's thickening, there's nodularity of that pericardium there, as well as further disease round the back here. Now, T3 at the pericardium means that it's into the pericardium, but not through it. Because beyond, if you've got transmural extension through the pericardium, that would upstage it to T4 disease. Now, how can we say this is into the pericardium, but not through it? And the evidence here is, again, we use a normal black stripe of fat that separates the pericardium from the cardiac chambers. So this is an example of T3 disease at the pericardium, where you've got invasion into pericardium, but not transmural pericardium, not through it. And there's no pericardial effusion either in this case. So T4 disease, the most advanced level of disease that we describe at imaging, and this again, it's more extensive invasion of normal structures like the chest wall. So if you've got invasion of the chest wall, it's multifocal, and unresectable, it's T4. If it's spread into the abdomen and into the peritoneum by direct spread, if it's into the mediastinal organs like the trachea or the esophagus or the heart, if it's into the spine, and as I say, if it's transmural spread through pericardium. So I'll show you a couple of quick examples here. And this is T4 of the chest wall, where you're now getting your eye in for this. We've got a rind of abnormal soft tissue all the way around this lung, encasing it. So that's all tumour. It's extending all the way around there. And here we've got tumour extending out beyond the chest wall. Beside this is the sternum or breastbone here. And the same patient at a different site, so multifocal invasion of the chest wall in through beside this rib here. This bright white line here is an indwelling catheter, drainage catheter to help rid of that pleural effusion. So that's T4 of the chest wall. This is gross disease extending through the diaphragm into the abdominal cavity itself. You know, a big obvious lump of tumour here is extending into the peritoneum. This is the stomach, which is getting compressed by it. So clearly T4 into the abdomen. This can be tricky. Mediastinal organ invasion can be tricky because sometimes you have tumour that's up against organs but without necessarily invading it, and you don't want to upstage disease unnecessarily. So this is cardiac invasion. Now here you can see this big plaque of tumour and tumour anteriorly, and you can see it's hard up against the right atrium here. But is it into the right atrium? It can be hard to tell sometimes. This is where the multiplanar reformatting comes into its own. So we turn the scan into a chronoplane, and you can see there's loss. We'd normally expect the smooth border of the right atrium to come up here like this, but here you can see this irregularity here, and that's clear evidence that it's invaded into the heart, making this T4 disease. So I've changed the setting here. This looks a bit different, this picture, doesn't it? And that's because this is on what we call now a bone window, which is a nice way to look at the bones. And the bones are bright white here, so we see them very clearly, the scapula, the ribs coming round the chest here, the sternum at the front, and the vertebrae at the back. So normally the vertebral body should be a kind of homogeneous white, and here you can see there's a plaque of tumour, so where that arrow is, and this kind of black hole within the vertebra, and that's evidence of direct tumour invasion into that vertebral body. So T4 at the spine there. So that's a quick run through nodal, the T staging of mesothelioma at the CT. The other section, the N and the M, I'll touch on briefly as well. So nodes, essentially, N0 disease means we can't see any pathologically enlarged nodes. That's easy. N1 disease is nodes kind of on the same side of the chest, the ipsilateral chest. And here's a couple of examples here. We've got a node in the anterior mediastinum, and we've got a node in the subcriminal region. Here's another place we look out for nodes because the spread here is quite common. These bright white dots here are the internal mammary vessels, and we quite often get wee nodes popping up beside these vessels. So that's a common place to look for nodes. N2 disease, beyond that, is supraclavicular on the same side or contralateral nodes. Now, meso is a kind of late metastasizing disease, But as patients are living longer with treatments and so on, we are seeing a population of patients now that are developing metastatic disease. And here's just a couple of quick examples. This is the liver in the upper abdomen. This black spot here is a metastasis in the liver. Here's another case with lung metastasis. The primary tumour is on the left side, but there's a bunch of white spots here on the right side which represent spread to the contralateral lung, so contralateral lung metastasis. So that's a quick run through what the mesothelioma looks like in terms of T and M staging. Now, and that's the main part of our own radiology, but we do also, as I was quite interested to hear the earlier talk about the amount of tissue acquisition that was done by image guidance. And that's another role that we have in radiology that I'll just mention quickly. So I think I had the impression that more often tissue for the diagnosis was obtained either from sampling pleural fluid or at thoracoscopy. But sometimes we will be asked as radiologists, can we sample the pleura? And we do that percutaneously with needles and either ultrasound or with CT guidance. So this is again a bone window, so it's hard to see the tumour. The tumour is in here between these bright white bits, which are the ribs. And this is my needle, which we have scanned. And you can see it's not quite pointing in the right direction yet. There's a tumour there. I'm pointing off here. But then with an adjustment, you can see the tip of the needle now lying within that tumour bulk there. And we can then fire a gun into that and take a bunch of samples, and hopefully that gets us the tissue that we need to make the diagnosis. So that's a quick run through CT, and it is the workhorse of the diagnostic and imaging process in mesothelioma. It's very widely available. We have good sensitivity and good accuracy for staging in most cases. It is a bit dependent on technique. Like I mentioned, we need to have thin sections. We need to have appropriate contrast enhancement. And early disease is definitely difficult. You know, T1 and T2 disease is difficult. And often what we will use a technique is we look for the absence of upstaging disease. So we look for the absence of mediastinal invasion or the absence of pericardial invasion. And by that we can infer that the tumour stage is earlier. Occult disease can also happen, and we use PET-CT sometimes to preoperatively, for example, to make sure there's no surprises. And we will sometimes pick up things in PET-CT that we haven't appreciated in the standard CT. So that's a quick run through, as I said. Now it's your chance to have a go. We've got a couple of cases that need staged. So this is now your opportunity to be a radiologist. Now, I realise this is a bit risky, and I'm going to just say beforehand that if you get this right, it's not because my job is easy, it's because the teaching was good. Okay? So here's a one. So who wants radiologist? Here's a scan, and this is a chronoscan. Now, I'm going to give you a starter for 10 by telling you the abnormality is on the right side. Okay? So I'm going to do this by a show of hands. So who's for early disease, T1 or T2? We've got one at the back there. Okay, good. Who about a bit more advanced, T3 maybe? Still no takers. So T4. So good, excellent, T4. So who's going to take us through this? Kevin, let's take us through. Why is this T4 disease?
Oh, Simon. Well, there's a big tumour invading through the right of the diaphragm.
Yes.
Into maybe certainly through the chest wall.
Yes.
And might be kind of nudging up to the cortex of the kidney.
Yeah, absolutely. So this is very advanced disease, isn't it? So well done, Kevin. That was good. Now, this is great because now everyone's sitting slightly apprehensively. I hope he's not got another case. Well, I do have another case. But anyway, so here is a tumour bulk here, and you can see it very extensive. This is very gross, isn't it? Into the chest wall. We've got probably rib destruction here, and Kevin's right. I think it's probably going to be into the kidney itself there. So advanced T4 disease. Well done, all of you. So this is another one. It's maybe a wee bit more difficult. So it's on a bone window, so that's a bit of a clue. So I'll give you a moment or two just to have a look at that. How well is that projecting? It's definitely projecting well enough. So early disease, T1, T2, any hands for T1 or T2? No? T3, anyone? No? T4? So no one has voted at all, apart from Selena. So, so that's reassuring. You weren't all confident about this one. So Selena's sitting there nervously. I'm not going to ask Selena because she's too far back, but I will point out. So these are the ribs. 1, 2, 3. The rib side here, cross section, and here just a wee nibble out of that rib. A wee nibble out of that rib. and a wee nibble out of that rib, or that rib. So that's multifocal chest wall invasion. Okay, and that's going to be unresectable because it's multifocal. Make it T4. I'm very happy to take any questions if you have them.
So one of the big discrepancies when you look at the Scotland compared to the UK's national data historically is in staging. And the UK data has much more missing data, so we don't really have any missing data from MATS, well, not much. But there seems to be, appear to have much more early stage disease. Do you think that's real, or do you think that's a reflection of how the staging system is used in non-specialist MDTs?
So I think that's a big question, and I have to say, I'm thinking about mesothelioma staging and preparing this talk and so on. I notice a big difference in myself from moving from the lung cancer MDT, where you get 1 or 2 cases of meso, to looking at meso case after case after case, surrounded by the experts in respiratory medicine and cardiothoracics. It's just much more rigorous, and I'm conscious that the surgeon wants to know, is there invasion here, is there invasion, what the stage of disease is, and I think it has certainly focused my mind much more on accurate staging, and I suspect it's the same around the country, where you've got lung cancer MDTs that do a bit of meso, and the radiologists are dropping in and dropping out, and I've seen 1 or 2 cases here and there. And it's only, I think, with the experience of having all that concentrated, that I think you inevitably get better at it, and you take it more seriously. I mean, I remember you'd have 1 case of meso every other week at the lung cancer MDT, and they would say, "Oh, we need to put a stage down for this," and you'd go, T3, But now, it really does focus your mind. So I'm not surprised by that, and I think it's probably a real finding. I suspect it's because the radiologists are getting better at it.
Yeah, because I think because by doing it, as you say, so rigorously and so systematically, and with experts like you and Gordon, actually, it does become obvious that so many patients have got early stage disease, and I think if you're using, I think a lot of MDTs maybe are using lung staging. So as soon as you've got a pleural effusion, you call it stage 4, and you look at the UK wide data, and it's loads of stage 4, and you think that just can't be right. I'm sure it's just probably moving forward. There's probably an education element that's probably, which is why we're talking about doing webinars, that we're talking about doing UK webinars or European webinars on imaging, probably because there probably is incumbent upon us who are organised now to kind of share that experience, and maybe because there's probably is an important message.
Yeah, there probably is.
Any questions?
Is that your experience, Gordon?
Yeah, no, absolutely. I think it's very different staging system to traditional lung cancer, and even CHLs don't do meso. I think it's a big difference.
Yeah, I think that's right. I think it's also worth mentioning the TNM, the early stuff especially is more being devised through surgical resections rather than from imaging. So we're trying to apply the imaging techniques that we have onto a kind of largely surgical classification. Hence why it's difficult with the early stuff. Yeah, and it might not be obvious to everybody, but it's incredibly unusual to have a staging system where the T descriptors, which describe the tumour, make no mention of size. So T1, 2, 3, 4, nothing Simon mentioned there included the size of the tumour. It's only what it's invading into. And so what Selena's, the volumetry paper that Mark referenced before showed that volume is, the amount that's there doesn't really change, and actually the lowest volume that we had in that paper were the T4 patients, because they've got a big lump like that one invading into one bit, but they don't have the whole pleura involved. Okay. Thanks, Sam. That was brilliant.